Welcome everyone. In this session, we are going to discuss about INI-SS, the general medicine part of INI-SS. Almost 35 to 40% of your questions in your INI-SS exams are going to be related to general medicine, and the other questions are going to be related to your specialty. So in this session, we'll focus on the pulmonology questions which have appeared in the general medicine part in the previous years, and what are the few topics which we feel will be important to you. In this next 45 minutes to 1 hour session, I'll try to cover different topics under pulmonary medicine. I'll highlight the updates that have happened in the last 1 year and the relevant topics from which questions may be asked. So I'm Dr. Ayush, and let us move ahead with the first. Let us discuss the questions. So the first question that we had from a recall. So please understand, these are recall-based questions. So the framing of the questions as well as the options may differ from what you might have encountered in your exams. So if you think there is any mistake, please let me know so that we can correct the questions. And if there are certain questions that I've missed, you can also type it in the chat box and we'll discuss these questions later on. So one of the questions that was asked was, if an OPD prescription is given by the physician, then which of the following is a true statement? So let us look at each option one by one. The first option was, FQ are the fluoroquinolones are the first line of treatment for uncomplicated UTI in non-pregnant women. So I assume they are talking about urinary tract infection. So when we talk about non-pregnant women, the first line of treatment for uncomplicated UTI is actually nitrofurantoin. So therefore, this option is incorrect. Next, antibiotics are not needed for uncomplicated acute bronchitis, irrespective of the duration of cough. So this statement is actually correct. Most of your acute bronchitis is actually viral in nature, and these illnesses are self-limiting. Therefore, there is no role for antibiotics. Very rarely is acute bronchitis because of bacteria. The only conditions where antibiotics can be used for acute bronchitis would be if the patient is suffering from influenza. That is, influenza is the cause for acute bronchitis, and the patient has risk factors like diabetes or an immunocompromised state, or if the patient is having COVID-19, and this COVID-19 again is the cause for acute bronchitis, and the patient has risk factors for a severe disease. These will be the conditions where you would like to give antivirals to the patient of an uncomplicated acute bronchitis. Otherwise, you only give symptomatic management and antibiotics are not needed. So this option is correct. The next option is, macrolides like azithromycin are the first line treatment option for acute rhinosinusitis. So this is incorrect. And this is because if we talk about acute rhinosinusitis, then the first line of management is actually amoxicillin. Similarly, when we talk about acute pharyngitis, then again, in most of the cases, acute pharyngitis is not bacterial, it is viral in nature, and therefore antibiotics would not be needed. If we assume that the acute pharyngitis is bacterial in origin, the most common organism is actually Streptococcus species. So if we talk about Streptococcus species, then again, the treatment of choice is actually amoxicillin. And clindamycin is only a second line therapy. So therefore, options C and D again are both wrong. So I've just tabulated what we have spoken. So if we talk about acute rhinosinusitis, then your preferred treatment is amoxicillin or amoxiclav. And the second line of therapy, if you cannot use penicillins, would be fluoroquinolones and doxycycline. Therefore, as you can see, macrolides are not recommended for acute rhinosinusitis. When we talk about acute pharyngitis, then if we think it is streptococcal in nature, again, the preferred antibiotic is amoxicillin. The alternative therapies which can be used if the patient has penicillin allergy is macrolides or clindamycin. Therefore, clindamycin is a second line of therapy. Apart from this, you should also know what is the treatment recommendations for community-acquired pneumonia. So this is the table that I've taken up from Harrison. So when we talk about treatment for community-acquired pneumonia, the treatment decision will depend on two factors. First, whether or not it is an inpatient treatment or an outpatient treatment. So whether the patient is admitted in the hospital or the patient is stable and is being managed as an OPD patient. And second, it depends whether or not the patient has risk factors for MDR organisms. So risk factors for antibiotic resistance. The most important risk factor is the use of antibiotic in the last 3 months. So when we talk about outpatient treatment, if the patient does not have any comorbidities, therefore there is no CLD, there is no CKD, there is no diabetes, there is no structural lung disease, and there are no risk factors for antibiotic resistance, then the treatment is either you give the patient plain simple amoxicillin or doxycycline, or just give a monotherapy with a macrolide, that is azithromycin. So no risk factors, no comorbidities, outpatient management, either give macrolide or just give amoxicillin. If the patient has comorbidities, therefore he has diabetes, structural lung disease, or the patient has risk factors for antibiotic resistance, then you have to give a combination therapy of both amoxicillin clavinate. So it's not plain simple amoxicillin, it's amoxicillin clavinate plus a macrolide. Therefore, a combination therapy is needed. Or if a combination cannot be given, you can give a monotherapy with a fluoroquinolone. Therefore, levoflox or moxiflox would do. Coming to inpatient management, so if the patient is sick, has a severe disease and needs to be managed inpatiently, then if the patient has a non-severe disease and there are no risk factors for MDR organisms, then again, you just give a beta-lactam plus some macrolide, that is amoxiclav plus azithromycin. If the patient has risk factors for MDR organisms, that is, there is recent hospitalization or recent history of antibiotic treatment in the last 3 months, then you add coverage for MRSA or Pseudomonas if the cultures are positive. Therefore, you do not give empirical MDR treatment if the patient is non-severe. You send cultures, you wait for the cultures report, and then you add MDR treatment. On the contrary, if the patient has a severe disease, and there are no risk factors, then same, you give beta-lactam plus macrolide. But if the patient has a severe disease and has risk factors for MDR organisms, then you cannot wait for the cultures to come. You have to give empirical treatment for MRSA as well as for coverage of Pseudomonas aeruginosa. So this is all about treatment for community-acquired pneumonia. Another question that was asked previously was, in COPD, what are the differences between emphysema and chronic bronchitis? And these were the 4 options that were given. So the first option was prolonged cough. So as we all know, emphysema is primarily involvement of the alveolar parenchyma, where there is destruction of the alveolar walls, which leads to enlargement of the air spaces. Whereas chronic bronchitis is primarily focused on the airway. It is a bronchitis. So chronic bronchitis will have more cough and more sputum, whereas emphysema will have more shortness of breath. So this is an incorrect option. Coming to edema. So edema in COPD happens because of cor pulmonale. And what is cor pulmonale? It is basically nothing but pulmonary hypertension. Why does pulmonary hypertension occur in COPD? It occurs because of hypoxia. And as we all know, chronic bronchitis is known as blue bloaters, whereas emphysema is pink furfurs. So hypoxia is more common in chronic bronchitis. Again, edema will be more common in chronic bronchitis. Coming to cyanosis, like we discussed, cyanosis, blue bloaters, it's more common in chronic bronchitis. And the last option, which is the correct option, was hyperresonant chest. So in emphysema, there's a lot of air trapping, there is hyperinflation. Therefore, if you percuss, what you're going to get is an hyperresonant chest. So this will be the correct option. So this is just a summary of the differences between chronic bronchitis and emphysema, blue bloaters versus pink furfurs. Just quickly, I'll go through this. So you'll have more cough and sputum for chronic bronchitis. You'll have more hemoptysis, cyanosis, and peripheral edema. And the patients will have polycythemia, cor pulmonale, and pulmonary hypertension. Coming to emphysema, the patients will be cachexia. The patients will be having hyperinflation or barrel-shaped chest wall. And in the complications, rather than having pulmonary hypertension, they are more likely to develop pneumothorax because of the presence of emphysema and bulla. Another question that was asked previously was on respiratory failure. So unfortunately, I was not able to recollect all the 4 options that were given. So we'll just discuss respiratory failure in general. So respiratory failure is of 4 types. Type 1 is known as hypoxemic respiratory failure. These are diseases where there is a decreased PaO2 and the CO2 can either be low or it can be normal. So these are diseases which affect the pulmonary parenchyma in such a way that the patient is hypoxic, has decreased PaO2, because of which the patient becomes tachypneic. And as the patient is tachypneic, they start washing out CO2. Therefore, either the CO2 is low or it is normal. Now, type 1 hypoxic respiratory failure can occur because of a variety of mechanisms. These mechanisms could either be a VQ mismatch, that is, there's a difference in the amount of ventilation and perfusion happening, or the patients can be having a shunt, which means that the blood is passing through the pulmonary parenchyma without coming in contact with the alveoli and there is no gas exchange happening. Or the problem could be that there is a decrease in the atmospheric PO2, which can happen in patients of high altitude. So how do you differentiate between all these three causes of type 1 respiratory failure? For this, what we use is known as the AA gradient. So what is AA gradient? This is alveolar arterial gradient. That is, you see the difference in the PO2 of the alveolus and of the pulmonary of the systemic arteries. And if the gradient is increased, this means that there is some problem at the level of the pulmonary parenchyma or at the level of the vessels. So it is increase in cases of VQ mismatch, it is increase in cases of shunt, and it is increase in cases where there is a diffusion limitation. Whereas if the AA gradient is normal, this means that the alveolar capillary membrane is normal. But in spite of this, if the patient is having a low PO2, this means the problem is in the atmospheric PO2. So this means there is a low atmospheric PO2. So you look at the A gradient. If the A gradient is increased, you're either looking at a VQ mismatch or you're looking at a shunt. Now, in order to differentiate between a VQ mismatch and a shunt, what you do is you give supplemental oxygen. So if after giving supplemental oxygen, the PO2 increases, this means the problem was a VQ mismatch. If the PO2 does not increase, that is, the hypoxia does not get corrected despite administration of supplemental oxygen, then you're dealing with a shunt. So this is how you go about differentiating the different types of type 1 respiratory failure. Common causes would be ARDS, pneumonia, or you can also have pulmonary embolism. Coming to type 2 respiratory failure, then type 2 respiratory failure is also known as hypercapnic respiratory failure. So the primary problem here is hypercapnia, that is increase in the PaCO2. So PaCO2, if it is increased, it is type 2 respiratory failure, it is not type 1. And in most of the cases, whenever there will be an increase in the PaCO2, then the PaO2 will also be low. Therefore, the patient will be having hypoxia along with hypercapnia, and this is labeled as type 2 respiratory failure. The common etiologies could either be related to the airways, for example, COPD, or the patients might be having some problem in their neuromuscular system, like severe myositis, myasthenia, or there's some problem with the spinal cord, etc. So this is type 2 respiratory failure. Type 3 is respiratory failure that occurs in the post-operative scenarios, and that is due to lung atelectasis. So there is collapse of the lung because of pain and because of the fact the patient is going to be lying supine most of the day. There is lung atelectasis, and that leads to respiratory failure, which is known as type 3. The patients can have hypoxia, and in severe cases, they can also have hypercapnia. Coming to type 4, then type 4 is a special type of respiratory failure that occurs when the patient is in shock. So when the patient is having shock, which could be septic shock, hypovolemic shock, or cardiogenic shock, then there will be a decrease in the perfusion of the respiratory muscles. If the respiratory muscles do not get enough blood supply, then they are not able to ventilate properly, and therefore there will be a decrease in the ventilation. And this decrease in ventilation leads to respiratory failure. And this kind of respiratory failure again is known as type 4 respiratory failure. Again, in these patients can have low PO2 and they can have high PaCO2. So this is all about respiratory failure. So these were the few questions that I had collected about the previous year's INISS General Medicine Pulmonology questions. Now I will look at the different topics of pulmonary medicine and highlight the important points that might be asked in exams, and I'll be focusing more on the updates. This is not going to be a comprehensive class, and because this is a recall and a revision video, I quickly go through things. Don't worry, I will be sharing the PDF or the PowerPoint as a link in the comment section, and you can download this presentation later on. So coming to asthma first. So in asthma, there are two things I want to know. First is what's the definition of severe asthma and difficult to treat asthma. So difficult to treat asthma is asthma which is uncontrolled or controlled only on step 4 or 5 of GINA. This means asthma that is uncontrolled or controlled on medium to high dose inhaled corticosteroids plus LABA. When this is happening, this is known as difficult to treat asthma. If this is happening despite ensuring compliance and despite correcting comorbidities, then this kind of asthma is known as severe asthma. So there's a difference between difficult to treat and severe asthma. So difficult to treat asthma is uncontrolled on step 4, step 5. Then we check for compliance. We correct the comorbidities. If the asthma still remains uncontrolled, it is known as severe asthma. So when we treat severe asthma, one thing that we do is phenotyping of the patients. So on the basis of phenotyping, you can have T2 high asthma or T2 low asthma. So in T2 high asthma, the cytokines that are responsible is IL-4, IL-5 and IL-13. In T2 low asthma, what we have is IL-2, IL-17, TNF-alpha and interferon gamma. So these cytokines are important. So what are the different markers that tell you that these cytokines are high in the body or the patient is having T2 high asthma? So the markers that we use is the absolute eosinophil count, which if it is more than 150 signifies T2 high. We look at FeNO, that is the fraction of exhaled nitric oxide. If it is more than 20 parts per billion, we can also look at the sputum eosinophils, which can vary from 2 to 3% as given in different texts and review articles. And another experimental molecule that can be used is a periostin levels. But practically what we are using is absolute eosinophil count and FeNO. So this is what we practically use. So if the patient is having a T2 high asthma, then we can offer biological therapy to the patient. So biological therapy are basically drugs that act against a particular cytokine and therefore decrease the level of inflammation in the body. So this is a very comprehensive table in which you need to remember the drug names and you should remember the mechanism of action. And along with that, you should remember the eligibility criteria, that is which patient can be offered what drug. So the first drug is omalizumab, which is an antibody against the IgE molecule. The important thing to remember is that when we talk about the eligibility criteria, then the patient should be having what is known as an allergen-driven asthma. That is, the patient has history or clinical features suggestive of an allergy, and the IgE levels should be between 30 to 700. They should not be more than 700, should not be less than 30. Important thing is the response to omalizumab does not depend on the IgE levels. The patient responds better if he has a T2 high asthma, but it does not depend on the IgE levels. The next molecule is mepolizumab. So it is an antibody against IL-5. The eligibility criteria is if the patient is having an AAC of more than 150 at baseline or an AAC of more than 300 historically. Also, it can be given to patients who have EGPA or who have hypereosinophilic syndrome. What are the predictors of response? It does well if the patient has T2I asthma. Along with this, if the patient has adult onset asthma or the patient has nasal polyposis and rhinosinusitis, then mepolizumab is what you need to use. Then we have reslizumab. So reslizumab is almost similar to mepolizumab. It is again an IL-5 antibody. The only difference from mepolizumab is that reslizumab is an IV therapy. It is IV therapy. Rest all of your biologicals are actually subcutaneous therapy. Coming to benralizumab. So the difference of benralizumab and mepolizumab is that benralizumab is an IL-5 receptor antibody. So mepolizumab and reslizumab are IL-5 antibodies. Benralizumab is IL-5 receptor antibody. Again, the eligibility criteria is similar to that of mepolizumab, and also the predictors of response are similar to that of mepolizumab. Next molecule is dupilumab. So dupilumab is IL-4 and IL-13 receptor antibody. One most important thing is that in the eligibility criteria of dupilumab, you have FeNO. So dupilumab is the only molecule that can be given if the FeNO is more than 25. For all the other molecules, you need a high AC value. But for dupilumab, only a high FeNO level is also sufficient to administer dupilumab. Also, it works better if the patient has dermatitis. The AC values for dupilumab are similar to that of mepolizumab. Lastly is a newer molecule, that is tezepelumab, which is an anti-thymocyte lymphostromal poietin antibody, anti-TLSP antibody. Why is this molecule important? Is because it can be given to all patients irrespective of their AC and irrespective of their FeNO levels. Therefore, if the patient even has a T2 low asthma, then tezilumab is one molecule that can be given to this patient. So remember, irrespective of AC is tezepelumab, only on the basis of FeNO is dupilumab, and all the other molecules are on the basis of AAC values. Last thing about asthma would be there's a slight change in the algorithm for asthma. Now what we prefer is track 1, which is in track 1, we administer the patient a single inhaler device that can be used as a MART therapy. What is MART? MART is that one single inhaler can be used both for maintenance as well as for reliever. So the patient uses this inhaler as a background therapy and also uses it when the patient is having acute symptoms. And the molecule that is used is inhaled corticosteroid plus formoterol. So as we know, formoterol has both long-acting properties. Also, it is fast-acting. Therefore, it can be used both for reliever and maintenance. So in track 1, we only administer one single inhaler device. Another change that has happened is that if the patient is not following track 1, the patient is following track 2. That is, you use separate devices for control and for reliever. Then even in this, if we talk about the reliever therapy, then previously reliever was only SABA, but now it is recommended that whenever SABA is used, even as a reliever therapy, then the patients should combine it with an inhaled corticosteroid. So your reliever will be as needed ICS plus SABA. That is one change that has happened over the last 2 years. The next disease is ABPA. So we'll cover ABPA extremely shortly. What I want to know is the diagnostic criteria for ABPA and the changes that have happened. So in the essential criteria, currently the cutoff for IgE levels is 500. Previously it was 1000, now it is 500. And another essential component is the level of IgE specific Aspergillus fumigatus, which is more than 0.35. So previously you had also had skin test, prick test for Aspergillus, but IgE is preferred over skin testing. The second thing is in the other components in which you require any 2 out of 3, you can have positive IgG against Aspergillus fumigatus, you can have high AAC of more than 500, or you can have CT or X-ray features. One important diagnostic point is that if the patient has HAM, that is high attenuation mucus, it is pathognomic for ABPA. So HAM is basically when the mucus is more attenuated, as in a higher attenuation as compared to the back muscles on the CT. If that is present, then the patient definitely has ABPA, even if the patient does not meet the other criteria. So if there is HAM, it is ABPA irrespective of the diagnostic criteria. Remember the cutoffs for IgE and the total IgE levels. If we talk about the treatment for ABPA, the first line of treatment is oral steroids. And if the patients relapse multiple times, then you can combine steroids with itraconazole, that is antifungal agents. Coming to COPD. So in COPD, I would like you to highlight the severity classification. So the first severity classification is on the basis of the FEV1 predicted values. So as we know, COPD is when the FEV1 by FVC ratio is less than 0.7 after bronchodilation. That is post bronchodilator ratio should be less than 70%. Now the grading is on the basis of FEV1 values. If it is more than 80%, it is gold 1, 50 to 80 is gold 2, 30 to 50 is gold 3, and less than 30 is gold 4. Next is the groups of COPD. You have 3 groups, A, B, and E. Previously, there were 4 groups that is still mentioned in Harrison, that is A, B, C, and D. But for the last couple of years, GOLD guidelines specify only 3 groups, A, B, and E. So group E are those patients who have increased hospitalizations or increased exacerbations. So if the patient has 2 or more moderate exacerbation or 1 severe exacerbation leading to hospitalization, those patients are classified as group E. Group A and B have low exacerbation risk. Depending on the symptom burden, if the symptoms are less, that is defined as MMRC 0 or 1, and a CAT score of less than 10, that is group A. If there is a high symptom burden, MMRC 2, 3, or 4, or a CAT score of more than 10, that is group B. This ABE classification is very important because this is what decides treatment for COPD patients. Two more things. One is what is known as a board index. So the board index is another criteria to assess the severity of COPD. It is basically consists of 4 components, each standing for B, O, D, and E. So B stands for BMI, O stands for obstruction, that is FEV1 value, D stands for dyspnea, that is the dyspnea on the MMRC scale, and E stands for exercise capacity as measured by 6-minute walk distance. So this board index is important because the higher the board index, the worse the prognosis. And if the board index is more than 5 or 6, then we actually refer the patients for lung transplant. Therefore, this is the importance of board index. The last term about COPD would be PRISM. So what is PRISM? PRISM is an acronym for Preserved Ratio Impaired Spirometry. Preserved ratio impaired spirometry. So as the name suggests, the ratio is preserved, that is FEV1 by FVC is more than 70%, but the patients have impaired spirometry. This means that the FEV1 is less than 80%. So if there is a patient who has risk factors for COPD, that is the patient is a smoker or he has emphysema on the radiology, you do a spirometry, the ratio is normal, but the FEV1 is low, then this patient cannot be diagnosed as COPD, but instead is diagnosed as PRISM, that is Preserved Ratio Impaired Spirometry. This is another newer term that has come over the last couple of years. Coming to the treatment of COPD, then the treatment is on the basis of the group A, B, and E classification. If the patient falls under group A, then the treatment is a single bronchodilator. What is preferred is a LAMA is preferred over a LABA. So if you have to choose one, you prefer LAMA, that could be tiotropium. If the patient has group B, then the patient is given a combination of LABA plus a LAMA. If we talk about group E, then the treatment depends on the AEC value. If the blood eosinophils are more than 300, this means the patient has high eosinophilic inflammation and this patient should be given a triple combination therapy, a triple therapy. That is LABA, LAMA, and ICS. Whereas if the AEC is less than 300, then upfront or the first treatment should be a combination of LABA plus LAMA alone, and ICS should not be given upfront. This is about initial therapy. This is about initial therapy. So now that you have initiated therapy, then if the patient is coming to you with recurrent exacerbations despite initial therapy, then how do you proceed? So most of your patients are going to be on either LABA plus LAMA or on a combination of LABA plus LAMA. So if the patient has an AEC of more than 300, then as we saw, directly the patient should be given a triple combination therapy. If the AEC is less than 300, then initially you try with a double combination therapy without ICS. If after a double combination therapy, the patient still has exacerbations, then you again look at the AEC. If the AEC is more than 100, then you can try a triple combination therapy with ICS. But if the AEC is less than 100, then ICS should not be given. So this is what is important. If the AEC is less than 100, then ICS should not be given at all. If the AEC is more than 300, then ICS should be added upfront. Between 100 to 300 depends on the patient. If even after a triple combination therapy, the patient still has persistent exacerbations, then recently a new molecule has been approved, and that molecule is dupilumab. So dupilumab is the only biological therapy that is approved for COPD. Only biological that is approved for COPD. And it should be given in patients who have an AEC value of more than 300. So please remember this. The other biologicals like mepolizumab, omalizumab are not recommended. The only biological approved is dupilumab, and it should be given if the patient is having increased exacerbations, has an AEC of more than 300 despite a triple combination therapy. Other therapies that can be used to reduce exacerbations are roflumilast, which is a PDE4 inhibitor. You can use azithromycin, and there is a recent new drug that is ensifentrine. Ensifentrine, which is a combination of a PDE3 and a PDE4 inhibitor. So it is another drug that can be used to reduce exacerbation. Lastly, we know that COPD patients can have chronic hypoxia. Therefore, these patients might require long-term oxygen therapy. Therefore, you need to be knowing what are the indications or cutoffs in which we give the patient long-term oxygen therapy. So the cutoffs that are given is if the PO2 is less than 55 or the saturation is less than 88%, then you should be prescribing long-term oxygen therapy. Or if the PO2 is between 55 to 60, that is the saturation is between 88 to 89%, and the patient has either right heart failure or secondary polycythemia, then again the patient should be given LTOT. So less than 55, definitely LTOT. Between 55 to 60, if the patient has right heart failure or has polycythemia, that is raised hematocrit, has peripheral edema, has pulmonary hypertension, then you give the patient long-term oxygen therapy. Next, coming to bronchiectasis. So in bronchiectasis, what you should be knowing is that coming to the diagnostic criteria for bronchiectasis, then bronchiectasis is a radiological diagnosis. On the CT scan, if the bronchus to artery diameter ratio is more than 1 to 1.5, that is the diameter of the bronchus should be at least 1 or more than 1.5 times of the pulmonary artery accompanying it, then the patient is said to have bronchiectasis. So you use the cutoff of 1 to 1.5. In most cases, what we use is 1. So that is about the diagnostic criteria for bronchiectasis on CT. Apart from that, there should be lack of tapering of the bronchus as we move to the subpleural areas, and you can have enlarged bronchial lumens within 1 centimeter of the pleura. So these are the three diagnostic features: diameter ratio of more than 1, lack of tapering of the bronchus, and presence of bronchial lumen within 1 centimeter of the pleura. That is all criteria for bronchiectasis. Coming to the most common cause in India, the most common cause of in India for bronchiectasis is actually post-TB bronchiectasis. So please remember, the most common cause in India is going to be post-TB bronchiectasis. Certain important info about bronchiectasis would be that depending upon the distribution of bronchiectasis, you can have different etiologies. When we talk about upper lobe predominant bronchiectasis, it is usually cystic fibrosis or a post-tubercular sequelae. When we talk about mid-zone or central bronchiectasis, it could be ABPA or NTM, and all the other remaining causes are actually a lower lobe predominant bronchiectasis. So just remember the upper lobe ones and the mid-zone ones. Coming to the different shapes of bronchiectasis, when we talk about cystic bronchiectasis, then you can have cystic fibrosis and PTB sequelae. When we talk about varicoid bronchiectasis, it is ABPA, and all the other bronchiectasis are actually cylindrical bronchiectasis. Lastly, coming to the treatment of bronchiectasis, then in treatment, what is important is a lot of patients of bronchiectasis will have recurrent exacerbations. So in order to reduce recurrent exacerbations, what we prescribe is long-term home-based antimicrobial therapy. We give the patient home antibiotics. So we just need to know what are the indications and what are the antibiotics that should be given. So firstly, the indication is that the patient should be having 3 or more exacerbations every year. So the patient is having 3 or more exacerbations in a year, then you first look for supportive therapy. You vaccinate the patient, you teach the patient airway clearance techniques, and then you prescribe the patient antibiotics. So how do you choose the antibiotics? If the patient is having Pseudomonas infection, if it is Pseudomonas, then you give inhaled antibiotics. Inhaled antibiotics. And the antibiotic of choice is either tobramycin or you give the patient colistin. If you have a non-Pseudomonas organism, other potentially pathogenic organism, then the treatment of choice is a macrolide. That is azithromycin. And lastly, if there is no pathogen, again you give azithromycin. So if it is Pseudomonas, you give inhaled tobramycin or colistin. If it is non-Pseudomonas or there is no organism, then you give a macrolide. If despite this, the patient is having exacerbations, then you can give a combination of the two. And if the patient is having 5 or more exacerbations, despite doing all of these, then you can give the patient cyclical IV antibiotics. So please remember, for Pseudomonas, you have inhaled tobramycin or colistin if the patient is having recurrent exacerbations. Another important topic is CTD-ILD. I'm sure that when you discuss the rheumatology recall questions and the high-yield topics of rheumatology, even CTD-ILD will be discussed even then. So let us briefly just cover CTD-ILD. One of the most important causes for CTD-ILD will be systemic sclerosis. So as we all know, systemic sclerosis could be diffuse SSC or could be limited SSC. And there is a number of differences between the two. In diffuse SSC, the antibody that we are dealing with is usually anti-SCL70 or also known as topoisomerase 1 antibody. And the pattern on immunofluorescence is nucleolar pattern of ANA. On the other hand, in limited SSC, the antibody is an anti-centromere pattern of antibody. Coming to ILD, then ILD is much more common in diffuse SSC as compared to limited SSC. Coming to pulmonary hypertension, then it is much more common in limited SSC as compared to diffuse. And in limited SSC, the type of pulmonary hypertension that you have is group 1 or class 1 pulmonary hypertension, that is direct involvement of the pulmonary artery. Whereas in diffuse SSC, the pulmonary hypertension that you're having is type 3, that is secondary to the lung disease. Why is this important? Is if your patient is having diffuse SSC and has pulmonary hypertension, then you do not treat it. Whereas if the patient is having limited SSC and has pulmonary hypertension, then because it is type 1, you give treatment to the patient. Then in diffuse SSC, you will have early and aggressive involvement, whereas in limited, there will be a gradual progression. Coming to the treatment of ILD in systemic sclerosis, then the treatment indications are either a low lung function or an extensive involvement on CT. So if the involvement is more than 20% or the FVC value is less than 70, either of them is met, then the patient requires treatment. What is the treatment options that you have? Then you can either go for cyclophosphamide or MMF or rituximab as your DMARD. Steroids should not be used in SSC patients because of the risk of renal crisis, scleroderma renal crisis. Other molecule that has been approved, if the patient has fibrosis in SSC, then you can give the patient nintedanib. That is an antifibrotic agent. Coming to another hot topic, that is myositis. So myositis can be associated with ILD, and myositis has a large number of different antibodies. So what you need to know is which antibody is associated with what findings. So when we talk about NXP2, TIF, and SRP, these are 3 antibodies which are not associated with ILD. These are not associated with ILD. The other features you can definitely read up in rheumatology as well, or just refer back to this table. When we talk about anti-MDA5 antibody, then this is very important because 100% of the patients have ILD. This ILD is acute to subacute. It is rapidly progressive and is lethal. And most of these patients will not be having myositis. It will be in clinically amyopathic dermatomyositis. One syndrome that is important is anti-synthetase syndrome. These are patients who have myositis, they have ILD, they have Raynaud's phenomena, they can also have arthritis, and some of them can also have mechanic hands. So a large number of antibodies can be associated with anti-synthetase syndrome. The most common antibody is anti-Jo1 antibody, and the pattern could be an UIP pattern. The other antibodies are PL12, PL7, EJ, and OJ. So the important thing about PL12, as mentioned, Harrison, is that it gives rise to a UIP pattern of ILD. And in PL7, the patients can be having fever. So try to remember MDA5 at least. This is important. Could be asked. It was asked in the recent NEET SS paper. And anti-Jo1 antibody. This is a table in which I've tried to consolidate what are the different pulmonary features seen in the different CTDs. I've only added a plus in those diseases and those areas where it is more commonly seen. Rarely all features can be seen in most of the CTDs. I've added a plus where it is more common. So I'll just go through this. For example, if we look at an UIP pattern of ILD, then UIP pattern is seen only in RA and it is seen only in SSC. Whereas if I talk about the LIP pattern, that is lymphocytic interstitial pneumonia, then it is only seen in RA and only seen in Sjogren syndrome. If we talk about DAH, that is diffuse alveolar hemorrhage, then again, it is only seen in RA, it is seen in SLE, and it is seen in mixed connective tissue disorders. So please spend some time on this table because a lot of questions can be asked. That is, what features are seen in what disease or which feature is not seen in any one of the diseases. Some of the important one-liner questions could be, what is the most common pattern of ILD in the different CTDs? Then almost for all the CTDs, the answer is going to be NSIP. NSIP pattern is the most common pattern of ILD in CTD, except in RA, that is rheumatoid arthritis patients, where the most common pattern is UIP. So please remember this. Second question that could be asked is, which CTD is most likely associated with LIP? So when we talk about LIP, the most common CTD is Sjogren syndrome. So please remember, in Sjogren syndrome, NSIP is more common than LIP. But if I talk about LIP, then the most common CTD associated with LIP is going to be Sjogren syndrome. So this is all about CTD ILDs. Next, I've just tried to tabulate the important features about the different CTDs, that is, which ILD is associated with smoking, is smoking related, or where smoking is protective. So smoking is protective in hypersensitivity pneumonitis and sarcoidosis. This can be used as a ready reference when you're revising. If we talk about wheezing, then wheezing can be seen in hypersensitivity pneumonitis and sarcoidosis. Pneumothorax can be seen in cystic ILDs like LAM, PLCH, and LIP. When we talk on the basis of CT features, then depending on the pattern of involvement, whether it is peripheral, central, upper, or lower zone predominant, then in the peripheral lung zone, you can have IPF and eosinophilic pneumonia. Centrally, involvement is sarcoidosis. Upper zone involvement is sarcoidosis, RBILD, chronic hypersensitive pneumonitis, and pneumoconiosis like silicosis, cold worker pneumoconiosis, and borreliosis. And lower zone predominant would be IPF, asbestosis, and NSIP. And this is the histopathological features of the different ILDs that you can have. Just read this once, may or may not be asked. Now coming to spirometry. So please don't get afraid by looking at this flow chart. We'll just briefly go through this slowly so that you can understand. Questions can be asked on the interpretation of spirometry. In this flow chart, I have consolidated or combined spirometry, DLCO, as well as body plethysmography. So the first thing that you have to do is you have to look at the ratio, that is the FE1 by FVC ratio. If the ratio is less than 0.7, that is less than 70%, this means that the patient is having obstruction. Next, if the patient has obstruction, you look at the vital capacity. If the vital capacity is less than the lower limit of normal, that is the vital capacity is abnormal, this means that along with obstruction, there can be restriction as well. You think towards a mixed defect. Therefore, what you look at is as the TLC, that is the total lung capacity. If the total lung capacity is also low, then what you have is a mixed defect. If the total lung capacity is normal, or if the vital capacity directly was normal, then this patient is said to have only obstruction. So low ratio, normal vital capacity, normal TLC, there's only an obstruction present. Once obstruction is diagnosed, you look at the DLCO. If the DLCO is low, this means the pulmonary parenchyma is involved. Therefore, the disease is emphysema. If there is obstruction, but the DLCO is normal, therefore the airways are involved, it is either asthma or chronic bronchitis, which can be differentiated on the basis of bronchodilator reversibility. Coming to the other hand, if the ratio is normal, therefore there is no obstruction. There is no obstruction. Then next, what you look at is the vital capacity. If the vital capacity is low, therefore there is a suspicion of restriction. To confirm the restriction, you look at the total lung capacity. If the total lung capacity is also low, therefore restriction is confirmed. Once the restriction is confirmed, it could be parenchymal or could be extra parenchymal, that is neuromuscular or the chest wall. For this, you look at the DLCO. If the DLCO is low, this means that the pulmonary parenchyma is involved. It is ILD. If the DLCO is normal, but there is restriction, that is the total lung capacity is low, this means the problem is outside the pulmonary parenchyma, that is a chest wall or a neuromuscular disease. If suppose the vital capacity of the patient was normal, the ratio was normal, this means that the spirometry is normal. There is no problem at the parenchymal level, but this does not necessarily mean that the patient is normal. What you have to look is, you have to look at the DLCO. If the DLCO is also normal, so normal spirometry, normal DLCO, then you call this patient as normal. But if the DLCO is low with a normal spirometry, then what you are dealing with is an isolated pulmonary vascular disorder like a pulmonary hypertension. So isolated DLCO, think towards pulmonary hypertension. So please go through this algorithm, and most of the questions that would be asked on pulmonary function test would be answered by this. Another question that may be asked is, you can be given certain pictographic images of a flow versus volume curve. So if there is a decrease in the peak expiratory flow and there is a scalloping at the expiratory limb, then this is known as a obstructive airway disease. So this is how your COPD patients will have their graphs. On the other hand, if the curve is shifted to the left, the curve has just become narrow, but the peak expiratory flow is still normal, then this is suggestive of a restrictive lung disease. And this is also known as a witch hat appearance. Now, if suppose both the inspiratory as well as the expiratory limb have both become flattened, then what you have is a fixed obstruction. If the problem is only in the inspiratory limb, then what you have is a variable obstruction, and this variable obstruction is occurring at the extrathoracic level. Whereas if the problem is occurring only and only in the expiratory limb, then what you're having is a variable intrathoracic obstruction. So I'm not going to go into the details of why this happens. Just remember, if both inspiratory and expiratory is fixed obstruction, only inspiratory is a variable extrathoracic, only expiratory is a variable intrathoracic obstruction. Coming to pleural effusions, then remember the lights criteria, which I'm sure all of you must be knowing, so not going into details. So there is a modification of the lights criteria that needs to be used if the patient is on diuretics and your fluid is coming as exudative, then there is a chance that the fluid still might be a transudate, and in those conditions you use this criteria. If all of these are met, then what the patient is having is actually a transudate and not an exudate. So this criteria should be used if the patient is on diuretics. Then again, these are certain clinical pointers seen on the pleural fluid tests that can suggest a particular diagnosis. Just keep this table and just go through it once. For example, if the pH is low, you can have complicated effusions, empyema, or an urinothorax. Amylase can be increased in cases of pancreatic diseases, esophageal perforation, and malignancies. So Harrison has an exhaustive table of all the list of exudates and transudates. I would recommend going through this table once and just seeing what cause you are not aware of. I'm not going to read out the causes here. I'm just kept it so that you remember to go through this list once and label the causes that you are not sure. Focus on the drug-induced pleural disease as well. The common drugs would be dasatinib, amiodarone, and nitrofurantoin. Another topic would be the difference between a pseudokylothorax and a chylothorax. So a chylothorax is an effusion where the triglycerides are more than 110. So if the triglycerides are more than 110, it is a chylothorax. If the triglycerides are less than 110, but the total cholesterol is more than 200, that is a pseudokylothorax. Along with that, chylomicrons, if they are present, it is a chylothorax. If chylomicrons are absent, it is a pseudokylothorax. One more topic would be, a question can be asked is, what are the indications of drainage of a complicated parapneumonic effusion? So along with bacterial pneumonias, the patients can have complicated parapneumonic effusions. So these are the list of indications where an ICD needs to be placed if the patient is having an effusion. Therefore, all these indications are where there is presence of infection in the pleural space. So if there is pus or there is low pH, low glucose, gram stain or culture is positive, this means there is infection happening in the pleural space and these patients need drainage. Coming to pneumothorax, for pneumothorax, just remember the ultrasound findings. So on the B mode of ultrasound, what you will see is an absence of lung sliding, which is the most sensitive feature. And the second or the most specific point is the presence of a lung point. So these are two features on the B mode. Coming to the M mode, then in pneumothorax, what you see is something known as the stratosphere sign or the barcode sign. So normally what you see is the seesaw sign, but in pneumothorax, what you see is the barcode or the stratosphere sign. As can be seen, these straight lines, they appear like a barcode. Whereas in a normal patient, what you see is this grainy sand appearance, that is a seashore. Coming to pulmonary hypertension, so the definition of pulmonary hypertension has changed. Previously, you had an MPAP of more than 25, but now the definition says that an MPAP of more than 20 millimeters at rest is defined as pulmonary hypertension. We diagnose pulmonary hypertension usually on the basis of echocardiography. What you should know is that on echo, what you calculate is actually systolic pulmonary artery pressure and not an MPAP. So what you derive is SPAP, and from SPAP you predict the MPAP. So how is SPAP calculated on the echo? It is done by using this formula where TRV stands for tricuspid regurgitation velocity. So 4 into TRV square plus right atrial pressure is what is the SPAP. So this is how you calculate. So your tricuspid regurgitation velocity square into 4 plus RAP. Secondly, pulmonary hypertension can be divided into pre-capillary PH, isolated post-capillary hypertension, and combined pre and post. So in pre-capillary PH, the problem is happening before the level of the capillaries. This means that the pulmonary artery wedge pressure, that is the pulmonary venous pressure, is going to be normal, which is less than 15. MPAP will be high because it is pulmonary hypertension, and the resistance of the pulmonary arteries will be high, that is more than 3 Wood units. When we talk about isolated post-capillary, the problem is beyond the capillaries at the level of the venous system. In that, the pulmonary artery wedge pressure would be high, that is more than 15. The MPAP would be high, and since the problem is not at the artery level, it's at the venous level, therefore your resistance would be normal, that is less than 3 Wood units. When we talk about combined pre and post, then both the pulmonary artery wedge pressure as well as the PVR, both are going to be high. So as we all know, pulmonary hypertension is divided into 5 groups, group 1, 2, 3, 4, and 5. So 1, 3, 4, and 5 all lead to pre-capillary pH. Group 2 leads to isolated post-capillary and can also lead to combined, whereas group 5 can lead to any of these because it is a miscellaneous group. Important about pulmonary hypertension is the classification of pulmonary hypertension. So there are 5 classes as we discussed. The first one is known as pulmonary arterial hypertension. So go through this list. Questions can be asked as to which disease lies in which class. So remember, in heritable PH, the most common mutation is bone morphogenetic protein 2 receptor mutation, that is BMP2R mutation. You can have drug and toxin induced. You can have CTDs, commonly is SSC and RA. You can have infections like HIV infection and cystosomiasis. You can have portal hypertension, and you can also have congenital heart disease. So remember, when there is left to right shunt is placed in group 1, whereas PH due to left heart disease, there's only either a systolic or a diastolic dysfunction of the left side, and that is placed under group 2. Then you can have group 3, that is lung diseases. You can have group 4, that is pulmonary artery obstructions. So just read the individual titles and remember the different causes so that if questions are asked, you're able to answer. Coming to the treatment of pulmonary hypertension, then the most important thing to remember is that pH-specific therapy is only approved for group 1. For the other groups, group 2, 3, 4, and 5, these molecules are not supposed to be used. The different classes of drugs that are available are these. You can have endothelin receptor antagonists, phosphodiesterase inhibitors, prostacyclin analogs, and 2 relatively newer molecules, that is soluble prostacyclin agonist, also known as selexipag, and you can have soluble guanate cyclase stimulator, that is Riausi-Gout. So these are the newer molecules. Just remember the mechanism of action as well. Coming to the treatment algorithm, then the initial treatment is if the patient is having a low or an intermediate risk disease, then what you give is a combination treatment. You give combination of an endothelin receptor antagonist plus a PDE5 inhibitor. Whereas if the patient is having high risk, then along with this, you also combine a prostacyclin. That is, you give the patient subcutaneous treprostinil. Lastly, talking about CTEPH, that is type 4 pulmonary hypertension that occurs because of recurrent pulmonary embolisms. Then the treatment of choice is surgery. That is the treatment of choice, whereas the drug of choice is Riausi-Gout. The first line treatment would be surgery, pulmonary and arterectomy. But if surgery cannot be done, then what you can use is Riausi-Gout. So this is all about the different topics I wanted to cover in this quick revision video. I know I've been very fast, but the aim of this session was to just highlight some important topics and to go ahead with a quick revision. So now if there are any questions, I would like to take them. I'll just go through the live chat, and if there are any relevant questions that I feel, I will answer them now, and I can answer the remaining questions in the chat box itself. So one question is, what are the normal percentage of FVC in PFT? So the normal percent of FVC is 80 to 120%. So 80% is what is the cutoff used. Another way of saying what is a normal is something that is defined as a lower limit of normal, which comes on the basis of the curve. So any value that is less than the lower limit of normal is considered to be abnormal. Any value between the lower limit and the upper limit of normal is considered to be normal. The third way is on the basis of Z scores. So any value that is less than minus 1.64 Z score is again considered to be abnormal. So we have a session on spirometry on the app where we discuss all the three ways by which abnormal PFT values can be defined. So another question, same question. So people have mentioned that a lot of different visual questions were asked. So if you guys remember what was the topic or you remember any of the images, then you can share it with me and we will again make a short video on this and upload it. So if there are no more questions, then I will end this session. You can always let me know if you have any other doubts and we will get back to you on this either on the chat box or through on a personal message. So we will close the session now. Thank you everyone for your patient listening. I hope this session was useful and we hope that we can keep making this content to help you with your exams. Thank you.